Good afternoon, ladies and gentlemen. It is my privilege to introduce to you Dr. Sundaram, an eminent psychiatrist who has dedicated his professional life to the field of mental health for the last 5 decades. After gaining his MD from NIMHANS and serving on its esteemed institution as a faculty member for 5 years, he transitioned into private practice in Bangalore, where he has been providing exceptional care for the last 44 years. Renowned for his teaching and mentorship abilities, Dr. Sundaram has garnered immense popularity among students and peers alike. His contributions to psychiatry have been widely recognized through countless rewards and accolades. In addition, he has enriched the scientific community with his numerous peer reviewed journal articles and book chapters. Richmond Fellowship Society is an NGO established in 1986 providing quality rehabilitation services for people with severe mental illness. Dr. Sundaram has been passionately involved in psychiatric rehabilitation for the last 36 years and was the honorary CEO of RFS Bangalore for the last 3 decades. And he's also been an honorary advisor for the last 6 years. An avid golfer and a dedicated mentor, he is continuously inspiring and guiding the next generation of mental health professionals.
Good afternoon, everyone. I'm Dr. Aditya, and it's a pleasure to introduce Dr. Sundaram. You can see his CV, his very impressive CV on your screen. We're starting on time because we expect this to be a really packed program, not only with his talk right at the beginning, but also the questions and interactions that we are expecting to have soon after. And the title of the talk, I think we chose it because it completely reflects Dr. Sundaram's expertise and experience in rehabilitation psychiatry. He's probably Bangalore's most famous, most successful psychiatrist, but also an extraordinary teacher and well-loved mentor to people across the country and beyond, but also someone who has very unusually helped create a very mature rehabilitation system in the one that I'm currently very fortunate to work in, which is Richmond Fellowship Society, Bangalore. It's also a real pleasure to welcome participants from across India. And I can see lots of colleagues, including from SCARF. It's such a pleasure to see you all. And also from the different branches of Richmond Fellowship Society, our interns. And so it's a real pleasure. Over to Dr. Sundaram, because I think this is going to be a really interesting talk that we're all really excited to be part of. Thank you. Dr. KS.
Thank you, Dr. Aditya. The name Masterclass was entirely Dr. Aditya's idea, and he chose the title because his ability to put things precisely and concisely is not matched by many. When we discussed the title, I said, you choose one. I think he chose this. I certainly hope to do justice to what he has given me to do. And I bring greetings from the entire Richmond Fellowship in India, and especially from Bangalore branch. And on behalf of the organizers, I would like to request everybody to switch off your mobile phone. And if you have questions, kindly put it in the chat box, which Dr. Aditya will moderate at the end of the program. So let's go straight on to what we are going to do. So this is about a time of this nature, 45 to 50 minutes will not do justice to all one wants to talk about psychosocial rehabilitation. What I want to do is touch upon some aspects of PSR that is pertinent to our day-to-day work. There are several NGO friends that are sitting here. Thank you, SCARF, for being here. And I think Chelamuthu Trust, they have agreed, they were going to participate. Aditya, Vikram, and all others from, not just from Bangalore, from across the country too. It's not going to be exhaustive, but I'm going to touch upon few aspects of rehabilitation, which I consider, having been in this field of rehab for over 35 years, as relevant and important because it impacts our day-to-day work with people with severe mental illness. What is that we can offer to them? What is that they can expect from us? Are we matching their expectation in the way it needs to be done? So I'm not going to read every line here because it's all visible to you. You are going to read all of it there, but I will take some highlights of this to expand a few points which I consider are very relevant and important. I think I should minimize, yeah, so that you can see me or you can hear me now. Okay, is that all right?
Yes.
Okay, so in way of introduction, it helps people with severe SMI to regain optimal functioning. The key here is optimal functioning, not full level of functioning. As you know, this disease over years will not permit, does not permit full recovery. Therefore, we are looking at optimal functioning. The optimal functioning also is very variable from person to person. I will talk about it a little later. I'm not going to expand about what is rehab in terms of halfway home, daycare center. No, I'm not going to expand on any of those things. Most rehabs are run by NGOs and not-for-profit organizations. There are some beyond that are initiated by family caregivers. Some are run by Good Samaritan. We will see examples as we go along. Several areas of work here are by the spirit of service and volunteerism. Majority people who work in rehab are doing free service, and because they want to volunteer in this area of work which they feel passionate about. Because there is no funding, such consistent funding from the government, most rehab centers charge what we call user fees. Fees for their stay and fees for their service, and sometimes, if not on most occasions, most people, if not all of them, will look forward to some funding, donation, sometimes from the government, which is often not available, and sometimes from private philanthropy and agencies. An overview, what are the key components of PSR? What we want to do is restore activities of daily living. I am often fond of saying, when you have an illness like schizophrenia, the structure in the brain completely gets disrupted, which results in simple routine things like people getting up in the morning, brushing teeth, bathing, changing dress, having breakfast or something to eat, or run to college or wherever they go to work. Unfortunately, none of these things happen for a homemaker. Routine activities do not seem to be important, or they go by the side and they don't function very well because the structure of the brain makes sure it is destroyed. And it is pertinent to mention here, schizophrenia, the prototype of a chronic mental illness, is a brain disease first and last. Other components that help for them to recover is vocational rehabilitation. We work on TC principles in Bangalore and Richmond Fellowship in general across the globe. TC principle is therapeutic community principles. When it was first introduced to us by Lee Hansen in the 80s, I was a skeptic. We have read about therapeutic community principles. Maxwell Jones started in USA around the same time Lee Hansen did it in London, in Twickenham, in Yorkshire. This brings in completely different kind of an understanding of how to function in a rehab center. We are hierarchy oriented. The boss, the second boss, and the third boss, multiple bosses beyond that, and then the rest of the other people who work in this. So we always look up to the boss and the boss and the boss. So it's a very hierarchical thing in the way our Indian culture is designed, used to working. In TC principle, all of them sit together in a circle. And TC principles, I'm not going to elaborate on it here, except to say, it looks at how do we interact with one another in a community. The entire community is a therapeutic environment. How do we interact with community in one another in the community? There are no rewards and punishment, and all behavior are looked into, discussed with the members being the clients, the patients, the staff, And all other people were involved in this. Admin people and the support staff, the kitchen staff, the helpers, everybody is involved in it. I'll come to that little later in detail. So we work on 3C principles. Although, as I said, I was a skeptic. Once Ellie introduced and conducted a few workshops for us, when we started working with that, we realized how workable it is. Today, we are very thankful that this has become a hallmark of our functioning. So medication and relapse prevention, no rehab can function if medication adherence is not there for people with schizophrenia. If a person is hallucinating or deluded or suspicious, you cannot engage them in a rehab. And also, it makes certain that you, to a large extent, you can prevent relapse. So the bedrock of any rehab works under the continuity of medication, which is variable from person to person. Work on individual and group therapy, skills training and yoga where appropriate. Remember, yoga here does not mean meditation alone. Yoga means predominantly physical aspects of the yoga, like Surya Namaskar and dynamic asanas and some amount of pranayama, and we do not allow them to do meditation, which can actually worsen. Dance and movement therapy is something which is catching up, which most patients enjoy. I'm not elaborating any of those things. What are the goals in rehab? We are looking at optimum level of functioning. This morning I heard from a friend's wife that a very close friend of mine, we all play golf together. He has been having some discomfort while walking and went for a checkup, found some change in his treadmill, and is gone for an angioplasty. 10 out of 10 who have angiogram and angioplasty, when they recover fully, practically fully, and you know that they will get back to working soon, wherever they had come from. But it's not so in schizophrenia. Optimum level of functioning means it's variable from person to person because there are several factors that intervene and interfere for a full 100% functioning to recover. Improve interpersonal relationship, very important in this management. We will talk about it more. Psychoeducation to individuals and families, often not paid sufficient attention, but I think it's very important. Remember, in this aspect, the psychoeducation needs to happen repeatedly. One time, two times, we think they have understood everything, but no, because they come from a background of not really knowing what is it all about, blaming themselves, blaming the family, blaming the patient, but they need to redraw their understanding. It has to happen continuously. Social inclusion and restoring dignity, to me, restoring a dignity of an individual is a hallmark of recovery of any disease, especially people with mental illness. They lose track of money, how to manage. We teach them money management, promote independence, and improve their quality of life, extremely important. Reduce hospitalization because we try and prevent relapses, but despite all our attempts, relapse can happen inside the rehab setup for varieties of reasons. We can discuss that again a little later. And of course, stigma reduction is a good point to remember to work on. Psychiatric rehab statistics of National Mental Health Survey 2015-16. You all know the approximate number of people who suffer. At least 1% of population suffer from schizophrenia alone, which is several crores of people. How many of them actually end up getting attention with rehab? We know at least 1/3 to 1/2 of people with chronic schizophrenia, if not more, will require rehabilitation at some point in their lives. But do they get it? Do they get given that opportunity? Unfortunately not, or on later. We also address individual suffering, family burden, economic loss, not just for the individual, because several members of the family have to take care of one person. There is a greater economic loss and social stigma, as we mentioned. Schizophrenia is a disease not just of an individual. It's a disease of the family, because entire family, an extended family, they suffer at different levels, and it takes on a big toll for the whole group of people associated with the individual. So, what do families want? I keep asking myself, we say we provide rehabilitation from our perspective, from the mental health professionals' perspective. Do we ask our families, hey, we say we want to provide you this. How often do we go and ask the families, what do you want? What do you want from your perspective? What do you think you want from the families? And we much less ask the patient, what is it you want from rehab? Let's look at what the families want. Surprisingly, I used to be sitting very early days in Richmond Fellowship in Bangalore when the so-called intake interview was taken, and family members will bring in patients referred by some psychiatrists. We ask them how long the person has been ill. There's a, various questions are asked. We take a brief history and then ask them to come for the details. Ask them, you've been ill for about 8 years. Ask the mother, do you know what the diagnosis is? No clue. They do not know the diagnosis. Has it ever been told to you? No. Have you ever asked the doctor, the psychiatrist, what is the diagnosis? What is my son suffering from? What's the problem with my daughter? No, they don't know the diagnosis. Do you know what is likely to happen in the next 5 years, 10 years to this person? They have no clue about prognosis. Either they're scared to ask, or the doctors who are treating them are not giving them the right kind of an information, which in my opinion, which I'm sure all of you will agree, is an absolute must and they should provide. Sometimes we duck under the fear that if I tell them what the problem is, they may get scared and run away. But it's your job. Those days, there were no Dr. Google. Today, before you say, hey, presto, there is not only Dr. Google and there is ChatGPT and AI, what have you. So they come with the wrong kind of information, but most often they don't know. What do the families want? They want an affordable and quality care. They want the best care. They want something that they can afford. And they come from all walks of life, middle class, upper middle class, lower middle class, very wealthy, extraordinarily rich, all range of people who come because it affects everybody across the globe. They also want skills training and transfer of skills. What is skills training? They have lost their skills to study, ability to work, ability to interact, ability to move in the society, not wanting to mix with the family members. When relatives come, they go and hide. They don't want to be part of the family group. They want those skills to be retrained. And importantly, they want the skills to be transferred to them. How do we deal with them when they get discharged? We used to have a practice in Richmond Fellowship here in Bangalore. Families would come every 3 months, then every 6 months to understand what we do, see what we do, learn from what we do, and then we transfer the skills of what we have learned to tell these people what has helped them over the few months of being here, 6 months or 1 year, and then teach those skills. Otherwise, when the patients go back, the family members deal and treat with them exactly what they did prior to their admission in the rehab center. The whole issue of expressed emotions, all of them come into play. This destroys everything that they have striven to bring up to a level of some understanding and recovery pattern. Sensitivity and openness of the team is something which comes to us sometimes from the family members. They feel sometimes the staff, I'm pointing with no finger at anybody, in general I'm talking about, they say we want the staff to be sensitive when we ask questions. They're sensitive to the patients, but when we ask questions, the family member asks questions. Some of the staff members think they are being questioned. They are being attacked. They are being suspected of their motive for asking questions. For heaven's sake, if they don't ask you, who will they ask? Where will they get the information from? Why do you get so threatened if you're asked a question? If you don't know, you don't not know. If we ask you something about what they should do, or what the patient is doing, or how long will it take for him to recover, if you have an answer, you give. If not, you ask your seniors. But if you're not sensitive, they get very disappointed, despondent, and get very annoyed sometimes. And the response that the seniors get from the staff is, oh, this family is a difficult family. I find it difficult to understand such so-called labels of difficult families. If they are easy families and good patients, why are they here? They are here because they can't they can't deal with it at home. They have come to you as a specialist. So more on this later. They want reduction in burden of care at home and outside. They want respite care whenever required. I'm going on a holiday. Next month, my niece is getting married. I don't think I can take my daughter, but can you keep the person for 2-3 months? And they also want crisis intervention. I'm at home after discharge. There is a trouble that is brewing up. She is unwilling to come because she discontinued medication. She does not want to get out of the house. Please, can you help take the patient to the hospital, to your center with the help of an ambulance? That's what they ask you. They also ask for, do you have a support group? Do you have a self-help group? So provide the information that you have. To me, they are very important. Something which I wrote 20-25 years ago on a presentation. I don't think this is any different today. The staff attitude, I'm talking about staff in the rehab. Again, I'm pointing at nobody, I'm talking about in general, how it is helpful for us to understand these aspects. There are positive impact and the negative impact. Showing concern and care, being compassionate, showing empathy, being tolerant to the patient and their behavior, being tolerant to their disturbance, being tolerant to their so-called annoyingly interference. All of them have a very positive impact. I thought they come and disturb you. I said, I want to talk to you for 5 minutes. You're busy. It interferes. But can you give me 2 minutes? I'll come back and spend 5 minutes with you. Is different from, go away, I'm not free now. Just imagine, if you were in the receiving end, how would you feel? It's a slap in your face. The face is not physical. Slap in your own confidence in yourself. Tolerant, beyond the call of duty. If you're tolerant, and the chances of impact is very big, very positive. Beyond the call of duty. We know that sometimes in a rehab setting, patients get into relapses, emergency. When you go out of your way, outside your office hours, take them to the hospital, middle of the night, come back to the workspace, look after them if a disturbed patient. These are all make a huge positive impact, not just on the patient, but on the families. A good team bonding, a good team is a very healthy team. On the other side, if you are authoritative, I mean, you are coming from a hierarchical thing. I remember one of the early days in our rehab here, we had a PhD psychology from a well-known institute in this country. I shall not name that institution. He came and joined. And in the very first week, he came and said, Dr. Kalyan Sundaram, I think your attitude of running this place, the way you're running, is completely wrong. I said, why? He said, I'm a PhD from such and such a big institute. And do you know who my guide was? So-and-so professor. And your patient want to call me by my first name? What do they think they are? Who do they think I am? I said, you are in the wrong place. If you think you cannot be part of their culture, part of their community, I think it's not really worthwhile. Then he said, I don't think you are doing a good job. In fact, you're the only one who gave orally a bad reputation, bad certificate to me and said, I think you're doing a bad job. I don't think I can work with you. Unwilling to learn. Sometimes, for whatever reason, you are taught by somebody senior, this is not the way to deal with it. You have to deal with differently, but your own personal idiosyncrasies, your own attitudes are preventing you from learning, which is detrimental to the recovery of the patient. Unyielding. I have said so, therefore you will jolly well do it. I've heard some staff telling, the patients, are you the patient or am I the patient? Am I the staff or are you the patient? I have studied, what I have studied, you jolly well listen to me. Now, this attitude is completely wrong in the health sector. Competing. Am I right or you are right? You are not here for a competition or winning a prize. Over involvement, the other end of it. Sometimes I've seen patients and clients, staff and clients, they get very involved. They exchange phone numbers, exchange WhatsApp messages, exchange, shall we go and have a cup of coffee outside? The point is sometimes this can go to a boundary violation behavior. This can be detrimental to the team because others do not understand what's going on, and this has caused a lot of confusion and disturbance. So what needs to be done? Staff burnout is a very important point in rehab. We work in a very tough atmosphere, very difficult atmosphere. We deal with people who may not recover for their lives. We deal with people who continue to have symptoms. We deal with an atmosphere which can be seen as overwhelming and negative background. And yet, if you have to work, it's not an easy job at all. It can try the best. It can make you feel rejected, dejected. Burnout is common. So every organization, it's incumbent on the organization to provide some kind of a support to handle staff burnout. I'm not going to details about what needs to be done. Interpersonal and intrapersonal issues amongst the staff members. That is why our experience of running therapeutic community is very handy, very useful. In therapeutic community, you're not pointing a finger about individuals. People mistake this. When I say I don't like what you said, is different from I don't like you. We are talking about a behavior. I don't like the way you said it. It's different from I don't like you. Very often people mistake the behavior and the individual. Therefore, the misinterpretations happen. Intrapersonal issues. You have a family member who is not well, who is in a hospital, who is in a coma, who is in an injury, who is going for a surgery. You are not able to concentrate. You need somebody to hold hand with you. So interpersonal issues cannot be held down into your system. It has to come out and discuss and find a positive way of coping. We have to work towards welfare and recovery of clients. That's a goal that we have. I believe in any setup, patience, persistence, and perseverance. With all that we do with a difficult set of population, they are not difficult. Remember, they have become difficult because the brain has made them like that. Differentiate their brain and the individual for heaven's sake. They not want to be difficult with you. They cannot help but being what they are. There's always an issue about should we have residential staff? The staff, not the one who is duty staff, the one we have accommodation. Can we provide 4 beds for residential staff? 1 is on duty, 3 are not on duty. Advantage, when there's an emergency, they chip in and come and help you out. But disadvantage, there is no boundary between your work hours and non-work hours. The clients and residents see you, they come and knock on your door, they want to talk to you. So I think we have to be clear about what we need to do, plus or minus. What are my dilemmas? What dilemmas that I have come across? How long to keep the patient here in a rehab? And let's say in a half year. If you go by the rule book, we say we keep you for 12 months to 18 months, maybe 24 months. But the Richmond Fellowship, Bangalore, other places is no exception. But other places, I'm sure they go by similar, similar views. Do we go by the rule book of sending you the 24 hours, or we go by the compassion and say, hey, the person has improved. If you send him back, he or she might relapse. The family members say, we don't want to take him back because he has done so well. We have took him twice. He relapsed. Please keep him longer. So I'm a sucker for compassion. Where I swing. How do we decide this? On a case-to-case basis in the interest of the family and the patient. Attitude of staff, support staff. It's very important in therapeutic community. It's not just about the professional staff or admin staff. The kitchen staff, the helpers, the liftman, the watchman. I'm asking for a more food. In Kannada, they say, or in English, I've given you enough food. Don't come and disturb me now. I'm busy. You think you're right, but the other person thinks he's being rude, he's being bullied, he's being assaulted emotionally. How do we do this? What do we do for these people? Because these people have no background knowledge or information on the disease, or what is this disease? They don't know. They come from varied backgrounds, some educated, some are not very well educated. Remember, education alone does not give you the right to be rude, but those who are uneducated, they have no knowledge about the disease. So we believe in providing them efforts to train them about what the disease is, how to deal with them, how to talk to them, but it's a continuous effort. It is often not successful. That does not mean we stop there, we keep doing it again. I'm often fond of saying rehab is a journey. It's a train journey which has several stops. Heralded stops, unheralded stops. We do not know how long the train will remain there. It may take a different route. And I will call it unforeseen pit stop, to use a racing driver's jargon. It stops and starts, fits and starts, because it's a continuous process. But every journey towards the positivity is a big step. But sometimes when the train is stuck, it takes a reverse journey, goes back to the previous station and tries to take a different line. In life and in rehab, this is not at all uncommon. It's a continuous process. There's no end point. My favorite, what's in a name? Schizophrenia. Even yesterday, the other week, I was in Nimmans talking on a similar topic, and one of the speakers said, "My schizophrenic patients, I saw red. I raised my hand and said, 'Ma'am, sorry, this is not schizophrenic.' I noticed that about 100 plus people are listening or more. I want each one of you to listen to this with attention. Schizophrenia is the name of the disease. The person is not schizophrenic. Ramesh has schizophrenia. Charu has schizophrenia. Charu is not schizophrenic. If you say schizophrenic, you transfer the disease onto the individual almost as if there is no differentiation between the person and the disease. I'm very particular about this. A person has schizophrenia, the person is not schizophrenic. My medical colleagues here will bear with me, Aditya and others. It is because we have been taught very wrongly, badly by our teachers and medical colleges. We were told he's a diabetic. We were told so-and-so is an epileptic. I realized how horrible it is. The person has epilepsy, the person has diabetes. Let us make a change. So my appeal to all of those who are listening, you will say, you will convert, each one of you, 10 people from stop using the word schizophrenic. We know there's a lack of support from families, they pay the fees, government support is not there. Maintain transparency and fiscal discipline in a work that you do in a rehab setup. Balancing income and expenditure is a very tough call in any NGO. 70 to 75 occupancy need to break even. Unfortunately, sometimes some of the families do not pay on time, which causes a lot of distress, discomfort for the NGOs to run. Some don't turn up for follow-up. Fundraising is a big challenge, is a major problem in many rehab centers. Some people have the capacity to raise funds, some people have the capacity not be able to raise funds, because fundraising is not an easy task. You have to go with the begging bowl. Those who go with the begging bowl, sometimes they've been called names and abused, but you have to have a thick skin when you want to go and ask for money, because you're not asking for money for yourself, you're asking for a cause. collaborating with like-minded NGOs. Several years ago, some of us attempted in Bangalore collaborating with other NGOs within the city so that we meet once in 2 or 3 months, understand the work we do. We know several NGOs are working in Bangalore. We do not know exactly how they work. What kind of a approach do they take? How successful they have been? Can we learn from them? So we tried having an inter-NGO kind of a gathering and kind of a conglomerate meeting once in 2 3 months, getting together and talking about their work. Somehow it took off, but it fell down. Maybe this is a time to look and see, can we collaborate with other NGOs within the city, those who are willing to come and participate and learn from one another. The last one in the red, it says everything. One of my tragedies is to see several fellow professionals, I'm talking about psychiatrists and psychologists and others, social workers also, whoever, their attitude toward rehabilitation is either non-existing or not much can be done kind of a approach. Many of them have not even offered this as an option for people with chronic mental illness, severe mental illness. If you don't tell them, how will they know? Many are content to keep prescribing medication, prescribing injections, but patients do not improve, families are suffering. Why not throw up the option? I asked everybody, if you have a broken bone, if you go for a surgery, you go to an orthopedician, the first thing he will say after discharge is, you have to do physiotherapy. Without physiotherapy, you are not going to get a full function. You've got to strengthen your muscles. You've got to strengthen your knee joint, thigh muscles, whatever, wherever surgery is being done. Will any of us say no to that? Why is that we cannot say yes to rehab? Think about it, please. What did I learn? Among several things, some examples. For any rehab center to function efficiently, you need a very strong leader who has a sense of ownership. What does it mean, sense of ownership? You must feel this place, I belong to this place. This place belongs to me. I must feel I'm part of this place, part of the ethos, part of the group, part of the staff team, part of the patient population, part the attender or a kitchen staff are all one and the same to me. If you think of working 9 to 5 and not worry about it, does not work in health sector, medical sector. We all know that we do not restrain ourselves from working from 9 to 5. We all have worked for 12, 14, 16, 18 hours a day sometimes. But that kind of a sense of belonging, sense of ownership must be there. Why a strong leader? Because what you teach is not what you tell them what to do. You show them what to do, and that's the way they will learn. If you don't do what you need to do, you tell them what to do. If that you are not doing, they are not going to learn, because willy-nilly you are an example there. TC approach, I've talked about it, picking the right team. Getting a right team in a rehab setup is very vital. I believe right team involves people who have a right attitude, people who have a right training to be a rehab professional. Unfortunately, you cannot, if you don't have a proper training, you may not understand rehab, you may not understand chronic mental illness. So a training where that is offered, it must be done. And we, on behalf of the CEO, I'm talking, we in Richmond Fellowship are the only one who did a 2-year program in psychosocial rehabilitation university program, master's level. We had to close it for some reasons, but we are very keen to run short-term program. Those of you who are listening and if you're willing to participate in our training that we want to offer, we'll be happy. In rehab and TC, it's non-hierarchical, as I said. Seating is circular because every member has the right to give opinion, has the right to have a say. Supervise but not interfere. No, the term I'm told used these days is micromanaging. Doesn't work because you never give a confidence of the person to do the job. Allow them to do, correct, don't interfere, guide them. Compassion cannot be taught. I'm very firm in this opinion. In our MSc program, we had a student who right from our school, pre-university, undergraduate, and our college, MSc, she was university ranked first. Brilliant. Her answers, you can go to the university and still read. So, complete, excellent. But she did not feel she belonged to this profession. When she applied for a job with us, we interviewed her, and she had the gall to say that I don't feel anything for these people who are sick. Needless to tell you, she was not selected. I would rather have somebody who is average, above average, understanding, but compassionate. One who is willing to, extend the hand and hold the hand in a person who is suffering, who is willing to sit and listen to somebody, who is willing to listen patiently when the person sobbing with pain of discomfort, pain of disease. If you don't have that kind of a compassion, you are not going to be successful. I believe this compassion is not easily taught. You have to be compassionate. You have got to be calm, collected, spend time, be with people, be available to them when they want. Then you are likely to be successful, and this can be infectiously good outcome. Rehab does not happen in a classroom. I think I'm sometimes very brutal in what I say. It's not a theory subject. It's a hands-on experience job. You cannot teach rehabilitation by talking about different theories and different models if you have not seen a single patient in your life. I have seen in my experience over several years, people come and talk about rehabilitation. Unfortunately, they have not seen a single patient in their life. We in Richmond Fellowship are fortunate because we see a patient every day. I've been lucky to have been part of their journey 38 years, and I've learned a lot from them. My best teachers have been my patients and their family members. Hands-on experience is mandatory. As the saying goes, if you want to be a gardener, you have to dirty your hands. You can't sit outside. One of our professors, Dr. Surya, said in one of his classes, you want to swim, if you want a swimming coach, if you want to swim, you have to dive into the pool, wet your toes first. Don't sit on the bank and teach them the different strokes, different methods, different energy, how the water is displaced. He said, don't be a professor of oceanography. The 10 Commandments. I mean, this is simple for you to understand. You can read it yourself. Your expectation must be really in a rehab center. The realistic expectations is variable from person to person. The outcome is variable. If you are blocked about the recovery that you thought might work is not happening, reassess what's going on. Go back, look at the history. Go back about the illness. Go back about the treatment given. Go back about the treatment that worked, medication that worked. Go back and find out what is blocking. Are you blocking it? The patient inherent disease is blocking it. The family members who come and go. Several times we have heard stories. Patients go for a holiday, 10 days, come back, and then their symptoms are bang on again. What is happening at home? Why do they come back and fall sick again? So reassess. Reassure the family and client. Every opportunity, reassure them and compliment them for little baby steps they're able to take. Hey, I saw you suffering last week. You're doing very well, man, today. You're smiling. I believe you went to work yesterday. How was it? How does it hurt? Ask you and give him a positive stroke. Reset your goals. On the day of admission, we have certain goals for each patient. In the next 3 months, next 6 months, 1 year, 2 years goals. That is based on your initial assessment, but that can vary from time to time. So reset your goals and don't be despondent if the goals come down from the expectation. Sometimes families have very high expectations. Sometimes this Treating staff team have a much higher expectation. We got to be realistic and reset your goals. Restore their dignity. Resilience. More than textbooks, where I learned resilience is from the families and the clients. You only have to understand the disease in its ramifications over years of suffering. And yet, there are patients who are sitting with us, they're smiling, they're laughing, they're joking. They go to eat, they go to see a movie, they dance, they sing. Where is this coming from? We sitting at home with so-called no illness, some disturbance at home, morning or evening, whatever. We think the whole world has collapsed around us. We think we will never recover from that state of mind. Look at them. Look at them. Hello, sir. How are you? Cheerful. And yet, when you make a diagnosis and look at the symptom, horrifying group of symptoms they suffer. But they are able to rise above that. The clients and families also. They don't give up because they look at the goodness of the family, goodness of the patients, and look at the recovery for them. Reassign when facing resistance. Sometimes I find patients do not get along well with a particular therapist. Don't bang your head against that. For some reason, two people do not get along. Perfectly all right. In a group of 30 people, 5 staff, 25 patients, 1 or 2. Within 4 or 5 members in the family, 2 people don't get along. But you cannot reassign to somebody else, the family member. He's with you. But here, don't challenge and say, I will prove myself. Sorry. And the bargain what? So reassign another therapist. Result is not instant. We live in a place of instant rava idlis and gulab jamun. The result is very, very protracted. Relearn. At every stage in life, learn something new from every patient, every interaction, every success, and every failure. Work towards reduction of stigma. Quickly, I look at 4 models in my thought. Recovery, respite, rescue, retention model. Recovery model, in my opinion, is the best model. Have improved and relatively stable. Deficits in social occupation function. Families are involved. They're willing to be engaged. Strengths are professionally managed. Team of highly trained staff and volunteers. High level of commitment and dedication. Best practice model. This is what an ideal rehab set would be doing. And involvement of the families goes without saying in this kind of model. Time and resource intensive, very few follow this model. Financial concerns, government support not easy. Affordability is a question mark. So recovery model is a model which is ideal to follow. So I've given some names. Those names over here, whose names are not here, does not mean they do not follow the model. I just picked some at random. MPA, RFS, Chalamuthu Trust, CAF, Paripurnata in Calcutta, Chaitanya. So all of these things are given on the right side are part of what we do in a recovery model. So out of 4 models, my belief is recovery model is an ideal kind of a model for us to follow. The second one is what I call the respite model. Fluctuating stability and there are residual symptoms. Some mild to moderate disability. Return to pre-illness level is not easy. They come here for a short duration, 1 to 3 months, because family members are going on a holiday, they're going for a wedding. As I said earlier, they want you to keep them for 1 month or 2 or 3 months, and then they take them back. They're not planning to keep them for long periods of time. We are happy living with that person, but please look after them for 2-3 months. Usually, it is the same patient with whom you have spent several months, years. They want to come for a short stay. New patients, it's rather difficult to think of short periods. Strengths enable to function at optimum level, reduce the risk of relapse because you're looking after them, and the burden on family is reduced. Less resource intensive, high level of commitment. Limitation does not challenge the user because you're not doing anything intensive. They are there, but they participate while they are there with the rest of the team. nothing special is happening, but not easy to replicate. Again, respite model, halfway home daycare, all of them can happen. These are the centers that provide this kind of a model. It's a brief period. They also can be given social skill training for the period they are available, occupational and recreational activity, and there is a booster dose for them on looking for activities of daily living. The third model is a rescue model. Clients clinically unstable and symptomatic, they moderate to severe disability, minimal or absent family support, often they are wandering and homeless. They are rescued. Community-based initiative, purely voluntary, altruistic, good Samaritan approach encourages activities. It can provide only custodial care in some centers. Some centers provide beyond custodial care, combining rescue and recovery model. It becomes an alternative institution. It's often individual driven. Replication is difficult to function without government and philanthropic support because these are brought in by individuals who want to provide this kind of a rescue model. We have examples: Banyan in Chennai, Samarpan in Indore, Chittadama in HD Kote, Kerala Federation for the Care of the Mentally Disabled. There's an auto driver in Karnataka who picks up people on the road, truck driver in Gujarat. There are many unsung heroes. The word heroes I'm using as a gender neutral word. Therefore, pardon if you don't see it differently. They care for basic needs. They provide food, shelter, and clean clothes. They don't claim to do anything different. Routine maintenance activities shared by clients, recreational group activities, vocational training. In some places, farming, some do dairy, some do candle work, some do kind of vocational activities that keeps them engaged and a sense of well-being. The last model is the retention model. As the name indicates, they are kept in retention. Moderate to severe disability, families present but not very engaged with either the team of doctors or professionals or with the patient. Usually upper socioeconomic strata, they are loosely structured, some ADL present, recreational group activities. Some care is better than no care at all. It provides respite to the family. Alternative to neglect and abandonment, this retention model. Changing lifestyle and shrinking family structure results in people coming and getting dropped in these retention centers. Limitations, they are predominantly custodial care and expensive, and there are families who are willing to do that because they have the money, they want to keep the person there. They become alternative institutions, unfortunately driven by profit motive at times. Ethical concern, one of the centers that kept patients some years ago, refused the family members to come and see, and the families went to the court, put a habeas corpus petition. The court came there to locate a person whom the family had not seen for 18 months. So this can go to extremes where there can be other ethical, moral, and legal issues, and also encourages families to disengage. In conclusion, Aditya, I'm finishing another 5 minutes, 3:30. Psychiatric rehabilitation is essential and good for recovery of individuals. We have made progress, public and private sector, but government support, if it comes, will go a long way in providing this rehab to larger number of people who deserve to get this. And again, our mental health professionals will have to look at rehab as an option as much as a new medication or a new injection. Addressing these concerns, we can provide support to millions. This is one of my favorite points when I often use it in this presentation. Some of you are familiar with Robert Frost, the poet. I will read it quickly. Two roads diverged in a yellow wood, and sorry I could not travel both. And be one traveler, long I stood, and looked on one as far I could to where it bent in the undergrowth. I shall be telling this with a sigh. Somewhere ages and ages hence, two roads diverged in a wood, and I took the one less traveled by. And that is rehabilitation. And that has made all the difference for me. I took this point 25 years ago when I made my first presentation, around my early presentation 25, 30 years ago. I used this to tell myself, I have been fortunate I took the road that was less traveled by. If others were fortunate or not, it is for them to say. I became fortunate and enriched by the work I have engaged with them over 35 years. And this I picked up 2 weeks ago in one of the WhatsApp forwards. There are several WhatsApp forwards you want to ignore. What is important? Ask the pupil, the journey or the destination. The master said, the company. To me, ladies and gentlemen, you are the company. That company is important for the recovery of people who come seeking help and trust you to give them the best that you can. Many of you have seen this. I think I shall not complete without showing this. The story about Zanzibar. One of the young boys in the age of 14, 15 developed schizophrenia. The parents, poor patients in Zanzibar in Africa, took him to the mental asylum. There's all a one-way traffic, remember, it's in Africa there. And the patient was admitted there, young boy. 30 years later, his classmate, who was now a doctor in Saudi Arabia, came to Kenya to see his family friend. And I was with that lady there because I'd gone to Kenya to see somebody. I was having lunch. This lady told the story of the doctor. The doctor said, I want to see this patient. That is this my classmate, my friend. We played together, we jumped together, we kicked football together, we stole mangoes together. I want to go and see him and see what happened when he went. This is it. The parents were so ashamed. The mother wanted to stay back. The father said no. From Zanzibar, they went to Tanzania. The boy says, please tell them I did not ask to be sick. I did not want to develop schizophrenia. I did not expect to develop this disease. I did not expect to be disabled. But there they are. Please, ladies and gentlemen, spare a thought for them because they know not what they are into. They know not what they are in for. They know not where they are heading. You are their guiding light. Show some care and compassion. Hold their hands, even if it means stretching yourself a little bit. What else can we do except you can give something that you have, you can give, and you're capable of giving, and you should give. Thank you very much for giving me the time and opportunity. Aditya, 3:30, bang on, I finished. Thank you all.
Thank you, sir. As you say, on the dot. Thank you for finishing on the dot. It gives us 30 good minutes for questions and answers. There are already lots of questions on the chat box. Those of you who haven't, please put in some questions. I think we may have enough questions to last us the 30 minutes. The first question, Dr. K.S., I think is a really good question. It's a very tough one, and I'll put it to you, which is, why do some people recover from a severe episode and start working, while others with a moderate level, I presume, of illness are not able to recover and start working again? This is the real mystery of schizophrenia, and I think it's a fantastic question from Mr. Vijay. Over to you, sir.
Aditya is always known to throw the.
I promise it was the first question.
No, I think it's a very realistic question because the honest answer is we really do not know. However, when we say schizophrenia is not one single disease, one single diagnosis, multiple presentation, multiple ways of presenting this disease, multiple symptoms, different core symptoms. And some of them respond well to treatment, some of them do not respond well to treatment. I'm sure Dr. Aditya will bear with me. Sometimes we feel, you're seeing a first episode person come within 6 months, everything is going to be hunky-dory, but lo and behold, patient does not respond to several things. Some people respond despite longevity of the story. Factors that may influence is continuity of medication, not stopping medication at all, and support that the family is able to offer, the right kind of a doctor, right kind of a treatment, right kind of a follow-up, right kind of an approach. Having said that, this is a template on which recoveries can be built on. I am often, quote this. If you go to a surgeon who's got 10 patients lined up for appendicitis, he can close his eyes, open the knife, open the, today, burn a hole in the area and pull out the appendix. All of them will have appendix on the right side. They go home next day. In schizophrenia, 10 people, 10 diagnoses, 10 outcomes. We do not know. But what we should strive is to make certain they recover with all the good things that we can offer them. But answer is, at the end of all this, tough call, but some people recover very well, some people do not. That's the nature of the disease.
Thank you, sir. The next question is from Padma of SCARF. What would you suggest as a strategy to deal with colleagues who are anti-PSR?
Padma from SCARF, I'm delighted to have you here, Padma.
I think it is Dr. Padmavati. I'm not sure.
I'm sure it is Dr. Padmavati. I call her Padma. We go back several years. I'm delighted to have Padmavati as the director of SCARF. I'm very delighted and very honored to be having Padma sitting here. Padma, I think we deal with this on a daily basis, Padma. We have all talked about it, frustrated about it, because it is easier to deal with acutely ill people and get them recover and pat yourself on the back and get kudos from every opportunity. Excuse me, the tea has come. Let me take a sip. So, but to make them convert, I think it's a tough call. And then I think if you do not have compassion, as I said, compassion has to be there with you to be in this field. But if you have to be a holistic kind of a psychiatrist, not an acute psychiatrist or not a drug-oriented psychiatrist, you will fall flat if you do not give the complete opportunity. I find it difficult to understand how you will not even offer them there is an option like this. And they come to know and they tell us, the other doctor did not even tell me something like this is there. So I think, Padma, we are all struggling it. But I think when we started working in rehab 30, 40 years ago, things were very bad. I think it is not that bad today. Hopefully, in the near future, the youngsters who are listening, my hope is with them. The youngsters who are listening here today, and they should understand that this illness as a component, as rehab as a component of a treatment plan, and that should be offered to everybody who comes there. I think they might be able to change the tone of our seniors who have not done it for several years.
Thank you, sir. I think the next question is from Ms. Mamta Devraj of, I think, Sumana Trust, who asks a really important question, a tough one. In the absence of rehab centers nearby, how do we attempt PSR for our family members?
Rehab centers are structures which provide an opportunity for these things. I would say, having been in this for quite a bit of time, halfway home and long stay home are labor intensive, cost intensive. At least provide some kind of a daycare facility. a group of people, if we are not able to get a housing for them, they should be able to get at least a place where they can come and go and learn some vocational rehabilitation, vocational skills. That you need some vocational instructors to come and do this. It is less cost intensive. To that extent, it provides respite for the families, some kind of a handholding, some kind of support and learning that can happen to these patients. I think that is the way we should look at that opportunity.
Thank you, sir. Mr. V. Shivaraman asks a question. Are there any proven techniques to measure the improvement in the clients after rehabilitation? And the second question is, if a person continues to have symptoms which are manageable even after prolonged medication for several years, is there any major risk in gradually reducing the dosage of medication to at least minimize the side effects of the medication? So I think there are two separate questions. The first one is, are there any proven techniques to measure the improvement of clients after rehabilitation?
Yeah, there are several scales that are used by people working in the area of rehab. And there are scales that can tell you what was the person's level of functioning. For example, social and occupational function scale, to take an example. So fast, what the level of functioning at the time of admission, what the level of functioning after intervention of 3 months, 6 months, or 9 months, and progressively you can plot the improvement or otherwise. The improvement in individual is a variable thing, as I mentioned, and not all people improve at the same level at the same speed. And there are several factors that impede the duration, medication, and other socio-cultural factors that may impede the improvement. And when the patient is not improving after years of treatment, they are plateaued, well, it's a point in what you're saying. Can we reduce the medication to a level of optimum usage with less side effects? That's an option one should consider. But as a clinician, I would all go out and say why the person is not improving. Is there anything that we have missed, anything that we need to relook, relearn, and then do something to make the person better than where they are? But as I said, some of them plateau about this improvement, and then we should be able to see that they are on a maintenance dosage, they are functioning, they are not allowed to deteriorate, and work are able to manage with minimal supervision. That should be the goal.
Thank you, sir. Aditya Vikram says PSR should be part of an MD psychiatry program and other degree programs in psychiatry and clinical psychology. Can you tell him why they are not?
I think, Aditya, you hit the nail on the head. Yes. MD psychiatry, I know MD psychiatry students are exposed to some kind of a rehab in some centers and not all centers. And I remember having a MD psychiatry completed student coming from Bombay and one of the very well-known hospitals, and said, "Sir, we heard of you, head of your team, head of your training here, and can I spend 3 to 6 months here?" I said, "What do you come for?" "They have done MD, yes. We have done rehab, yes. But what I learned in rehab is what I know, understand is rehab." He said, "What we are taught is just some concepts of rehab, but we don't have any rehab center even to experience that." That's what I meant. So I think if every hospital, every MD training program in different centers in the country should not really offer, if they offer, as I said, it cannot be a theory subject. It should be coupled with a hands-on experience in working with people with rehab. Some of the centers send them over. We are sending them to you for a one-day orientation. I call them window dressing, window shopping. You walk through, see, you don't understand what it is, but you think you have done your job. In your curriculum, you say, "We have been to rehab center." What have you been to rehab center for? So what's the purpose? So I think that is the reason why even in MPhil courses, which was being done in immense those days, you would have MPhil past students coming over, but they have had very little knowledge or experience of working with rehabilitation. We have to teach them the components of rehab even before they could assimilate and then work with us. So I agree with you. It is just not in the curriculum. Coupled with the curriculum, the hands-on training component, if it doesn't happen, it just remains a theory with no practical output or benefit.
Thank you, sir. The next question is from Aditya Vikram again. How can we advocate for government and civil society support for psychosocial rehabilitation?
The one who has given years of his life to this is Aditya Vikram. If anyone can learn how to approach the government, how to, bring them down to their knees if possible, how to go and put a PIL in the courts, how to name them and shame them, Aditya is an expert in it. In fact, we are all learning from him. But in spite of all that, if the government, quote unquote, whoever is responsible for that, not giving enough importance to this, it says, a whole lot of things about who these people are. In fact, sometimes Aditya is very well aware of it. You talk to somebody in the government who's well up in that area of work, expertise, and in 6 months' time, he or she has retired, and the new person comes. The new person does not want to take any responsibility what the previous man has signed the papers for. I don't know anything about it. I don't want to give okay to this. So the culture has to change. Their understanding has to change. But the question is, do they want to change? Are they willing to change? Are they willing to listen? As often it is said, unfortunately, if they have not had somebody with an illness of similar nature in their family or somebody near and dear one, they don't understand this. They don't see the value for this and they don't come forward to help. There are schemes, I'm told, in the government that every district center must have rehab homes with certain number of people to be admitted. I've seen it in the papers. When the team was thrown up, we put up our hands and say, hey, here we are, we will train them. We will train people who will go and work there. But nothing has happened so far. But it's a tough call, but a very important point to be remembered. Yes.
Thank you, sir. Ritu Sharma asks, I think, a very important question. Is it a taboo to shift a person with mental illness to a rehabilitation facility if the family is not able to handle them at home?
Okay. If you keep stigmatizing about his illness, it'll be a taboo. But I think as a part of a treatment plan for them, this is essential. If somebody has cancer, would we admit a person for chemotherapy? Would we take them repeatedly for a few sessions of chemotherapy? Is it a taboo? Somebody has a chronic kidney disease. We take them periodically for renal dialysis. Would you consider that as a taboo? Or would you see as a part and parcel of a treatment plan? We even plan when we start kidney dialysis, you're already planning 3 years down the line for transplantation. Is it a taboo? We don't see that as a taboo. But when it comes to brain, rehabilitation is happening because the brains of these people are suffering. Because we don't see that. So we must give equal importance to the brain as we give importance to other parts of the body. Permit me to digress, Aditya, I've said this before. You see how many new corporate hospitals get popped up every now and then in different parts of the city, different parts of the country, saying we have this specialty, that specialty, left nostril, right ear specialty, left eyeball specialty, lower lip, upper lip, shoulder, blah, 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 specialists. Have you ever seen them advertising? We have a psychiatrist on our board outside in the beautifully lit specialist name that have popped up. It will be camouflaged inside mental health. Sure, it's mental health. You're ashamed to say there's a psychiatrist in our board. That is how we are. And who are responsible? Our own medical colleagues are responsible. I'm being blunt and open about it. Therefore, under the perception changes, and this will not change. But I think it is very important that we address this issue. We have to understand this is part and parcel of every treatment, and rehabilitation is a parcel of a treatment for a brain disease.
Thank you, sir. And apologies to the audience. I have cherry-picked the questions that are most suited for this talk on psychosocial rehabilitation. There are some very legitimate questions about schizophrenia that I have skipped. If we have time and Dr. KS has time, I'll come back to them at the end, but I'm just going to continue picking the questions that are most, I think, appropriate to this talk. Dr. Lata Hemchand, Dr. KS, you may know her, very senior psychologist, asked this question: what is your opinion about professionals providing psychosocial rehabilitation through home visits? Because many family members request this.
I was hoping Lata will answer this question, but she has asked this question. Now, I think we are in a frame of mind today to provide assisted care. Assisted care for people who cannot come to the hospital or rehab center, but they have been seen and they have recovered, and they are in the recovering process where the care is provided and assisted care is provided at their doorstep. If assisted care is providing weekly or monthly injections or providing some kind of a support to the client and the family, if this is extendable to some kind of a therapeutic support with the qualified people who are trained or who are experienced in providing this kind of a therapy at home, once the pros and cons are well discussed before this is undertaken. Because when we go into therapy at home, I think it is important to understand what is our goal, why are we doing this, what is the purpose, and which family member is going to be supportive, how do we go about it. If all those things are discussed and planned, I don't see why this cannot be part of a team effort. If nurses can go and give injections and come in those countries, if we are talking about assisted living, we are talking about home care. Home care can also include this in specific cases. Yes.
Thank you, sir. Ms. Soumya asks a complex question. Why did RFS stop its MSc Psychosocial Rehabilitation course? RCI is now permitting private universities without rehab centers to run MSc in Psychosocial Rehabilitation. So the question comes back, why did RFS stop its MSc in Psychosocial Rehabilitation?
I have been asked this question in the last several years. It is like saying we conceived and delivered a baby in 1999, conceived in 1997 and delivered the baby in 1999. The child grew up to 16, a brilliant young adult, and lo and behold, and we could not bathe, feed, or clothe the child. Euphemistically speaking, we did not have the wherewithal or money to support and run this course. As some of you know, we were the only one in the country who did this, ran this course. RCA recognized, Government of Karnataka recognized, NAC and UGC recognized. With great discomfort, we had to discontinue the course because we did not have the money to run this being an NGO. And many people told me, what doc? People run the course to make money, you run the course to lose money. Well, maybe that. So we did not have the wherewithal to run it. But it was a great experience and an excellent learning from all of us. If RCA is running a program providing psychosocial rehabilitation without having any rehab centers, it is like I told you, cut and paste professores with no practical experience. God help them, but I feel bad and sorry for that.
Thank you, sir. There's another question. Are there rehab centers run by the government in our country?
I know some government hospitals or institutions of mental health, they have rehab centers. For example, Nimban, for example, they have a daycare center, a well-run daycare center, which had been in existence even when I was a faculty member about 45, 50 years ago there. So that is still running there. They have a well-run daycare center. I don't know whether they have a halfway home inside, but they have an extension in a Sakalvara where there is a residential facility. Some hospitals, some mental health institutions, they have a extension of a halfway home in some block inside the campus. Some run daycare centers. In my opinion, every mental health institute must have at least a daycare center, if not for patients from outside, at least for their own patients who come there to the outpatient, just fill up prescriptions and go. I remember as an intern, we used to have an OPD called Madras University 1917 Madurai. The OPD called repeat OPD. Repeat OPD means 500 people will be waiting. They'll come with a sheet of paper, no prescription pad. The sheet of paper will say one B complex, one something equivalent to crocin. We will say repeat all, repeat all, repeat all. That's what happens. What should happen is beyond that. So I think every center must have. Government must take this initiative because it can only happen if people's movement pressurize the government to provide this setup for those, at least for those who are in the hospital, and every center must provide some help.
Thank you, sir. And this is a question, I don't know if you can answer this, but Vimala asks, well, where can I get information on working or training for a rehab center? I'm imagining that Ms. Padma, you can give them information about hours and maybe about SCARF and MPAs here. Maybe if we can give information, would that be correct, I think, sir? Or do you think there are any other courses that you would recommend?
I think we need to, as I said, as a collaborative effort, we must have a directory of people who work in this area because people come from different parts of the country looking for some help and support. If you can create a directory with like-minded people who are all sitting here with us and our contacts, we can create a directory. And this being online age today, this should be available digitally for anybody to click and find out which is the nearest place that I have to send somebody for a rehab. I think it's an effort that is worth made.
I think we have time for two questions, sir. And I think the one question from SCARF, from the team at SCARF has, sir, what has been your greatest lesson learned from working in PSR? What has been your greatest lesson learned from working in PSR?
When I came to 1988 to the center, my former teacher, Dr. Reddy, called me one day and said, I was at a party at that time and called me. I don't know how he got my number. He called me and said, Kalyan Sundaram, you are practicing. That is enough of practice. Come and meet me tomorrow. You know, once you are a teacher, you're always a teacher. Once you're a student to him, you're always a student to the teachers. So next day, he said, come and meet me. He asked me to come here and said, do you know about Richmond Fellowship? I said, I don't know. I've never heard of it. How much do you know about rehabilitation? Nothing, very little. I wanted to be a part of that. And as the saying goes, Vini, Vidi, Vici. I came, I saw, and I was content. What is the greatest lesson? The greatest lesson is to see people with severe illness making baby steps. Gives me immense pleasure. Greatest lesson is to see them smiling, see them waving when you come, and telling you, please come again. When are you coming again? Why have you not come? What does it tell you? It tells you that you are touching somewhere, something in their heart. For the recovery process, you've been part of the journey. I tell them, I will hold your hand, I will walk with you as long as you want me to walk with you. I think the opportunity that has been given to me to be part of this is the greatest wealth and lesson. And I tell people, and people know who know me, they know I eat, breathe, sleep, dream Richmond Fellowship and rehab. So what is the greatest lesson? It is possible to make every individual get better, provided you put yourself in their shoes and walk with them. And you are full of you, all of you together. And if you walk, others will follow. And that I think is the greatest lesson. And I'm humbled by the people who are around us, who look forward to their improvement and recovery. And they look up to you and are able to provide that and whatever capacity you are capable of.
Thank you, sir. And the last question, if I may ask you, is who should pay for rehabilitation? Many of our patients are people, by virtue of their illness, cannot earn money, cannot finish their education, cannot work anymore, or if they can work, not at the level that they used to. And so they are under the care, if not the full care, then the financial assistance of their families. The government can only do so much. So who should pay for rehabilitation?
Aditya's first question and the last question. I think it's a responsibility of the community and the family and whatever else can afford to do that for them. We have a lot of corporates who come forward to support several causes. And I don't think we're tapping them enough. Several corporates come forward to provide, I often tell people, rural water, sanitation, energy, children, physical disability, all of it. There are centers who provide support for people with physical disability for job opportunities. The same intensity is not there for people with mental disability. So who should pay for them? Some families can afford to, some families cannot afford. I think if we make a concentrated effort to make this, big corporates understand, their support would mean a lot to those who cannot afford to, and it will mean a life regained, a paradise lost and a paradise regained. I think we need to be the catalyst that can and should make it happen. A tall call, but I think an effort must go in that end, because individuals are unable to, and families can only support for some time, because the families are, moving away. Individuals are running with their families, their siblings, and government. I don't think either they have the wherewithal or the, should I say, willingness or their desire to look into this seriously enough to provide support for those who cannot provide for themselves. It's a collective effort from everywhere. Yes.
Thank you, sir. We started on time. You finished your talk on time. And now I think that brings our questions to an end. And I think we've had an amazing audience. There's so many colleagues, so many people from different walks of life, so many people in advocacy, so many family members and patients. And a lot of our students have come today. So thank you very much for this talk. And I suspect we will be asked to do another one very soon by the people in the meeting. And I'll come back to you with a request very soon. On behalf of all of us, thank you very, very much.
Thank you, Aditya, and thank you.
Thank you.
People who are there, and we looked at 100 as a number, but actually to put the numbers perspective, SCAF, one name, about 20 people there, and our center, 2 centers, about 20-25 each. Manasa, about, I think we're talking about 160 to 170, which is a very satisfactory number if the message has gone across somewhere about how important rehab is in a person's life of illness and recovery. Without rehab, recovery becomes incomplete, recovery gets stunted. Thank you very much for giving this opportunity and listening to me patiently. And as you know, I'm addicted to speaking, talking, teaching. Whenever my boss Aditya says, "Sir, will you do one more?" I don't say no to whatever knowledge that I have. Thank you for being with us. Thank you.
Thank you, sir.
Thank you, sir.
Thank you to everyone in the audience.
Thank you.
It's been a pleasure.
Thank you so much.
Thank you.
Thanks.
Bye.
Bye. Bye.